The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon. Welcome to Maximizing System-Level Data to Address Health and Social Complexity in Children, a spotlight of efforts in Oregon. This is Colleen Ruland, and I am the Director of the Oregon Pediatric Improvement Partnership, and I am so excited to be here to share a collaborative effort with my colleagues from the Oregon Health Authority. I have the honor of presenting today with Dr. Dana Harganani, who is the Chief Medical Officer at the Oregon Health Authority and a practicing pediatrician. As well, I have Dr. Collins, who is the Interim Deputy Director for Behavioral Health Services at OHA, and who was the Director of Health Analytics during the time at which the data we will be presenting was collected and reported. A few housekeeping items before we begin. We want this to be a lively discussion and encourage attendees to ask questions, but the lines will be muted. You can submit questions in the GoToWebinar question box. A recording of the webinar and the slides will be posted and shared with all registrants via email. For today's agenda, we are going to start first with an overview and background about why my organization, the Oregon Pediatric Improvement Partnership, and the Oregon Health Authority were interested and invested in work that would leverage system-level data to create a focus on children with health complexity. Then we will briefly go through the specific methods and data sources used to operationalize this novel methodology for identifying, and then share the findings for the publicly insured children. Then we will talk about our plans to go from data to action and how we are planning to use the data at a state and system level. Lastly, we are saving time for questions because we want to make sure to hear from you and answer your questions based on your review of the memo. Speaking of the memo, an important note, a compendium summary brief was provided to all attendees of this webinar beforehand, and it is available in on the Lucille Packard Foundation for Children's Health website. It's also a link to it is also in the chat function of the webinar. This document provides a very detailed summary of the state level report of the findings that we will be just touching on a high-level summary of today. First, a little background about the Oregon Pediatric Improvement Partnership, or OPIP. OPIP is one of over 20 improvement partnerships across the country. We support a meaningful, long-term collaboration of stakeholders invested in child health care quality with the common purpose of improving the health of children and youth in Oregon. We are fortunate enough to be based in the Department of Pediatrics at Dornbecker Children's Hospital at Oregon Health and Sciences University. Which leads me to the focus of the summary brief and the specific grants that we received to work with OHA. We know that if we want to make a meaningful impact on children's future health and preventable chronic conditions, we need to address the predictive social determinants of health and build resilience. In order to do this, we need a population and community-based approach that engages the multiple sectors required in addressing children with health complexity. Since 2010, OPIP has been working with primary care practices and health systems on how to better serve children overall, and specifically children with special healthcare needs. And what we have found here in Oregon is while there have been significant gains made in ensuring patient-centered medical homes for all children, and the development of coordinated care organizations in Oregon has supported higher quality of care for publicly insured children, there was still a gap in the specific supports needed focused on children with health complexity. The reasons for these gaps range from staffing and resources within the health systems to gaps in community-based systems. We also know that what is measured is focused on, and what is paid for is focused on. And yet we had no metrics focused on children with health complexity, and there were barriers to payments for the kinds of services that are the best match for children with health complexity. As an improvement partnership, one of our core functions is to convene public and private stakeholders on a shared goal of improving the health of children. So in August of 2016, we convened state policymakers and health system leaders to talk about the gaps in care for children with health complexity and to talk about the need for a standard definition and standard way of identifying children with health complexity using system-level data. These stakeholders agreed on this need, and from there, the grant to Lucille Packard Foundation for Children's Health was born. So now let's hear from Dr. Harganani about why the Oregon Health Authority was interested in doing this work with OPIP.
Hi, I'm glad to share the Oregon Health Authority's perspective, and we were truly honored to be a partner in the work that we are sharing with you today. The Oregon Health Authority and Oregon in general has been working hard to transform our health system for many years to improve the health of all Oregonians, but also in particular those of children and families. But we also know that we have tremendous work to do still. We know that children and families face significant obstacles to improving, to getting the care and the health that they need. And we know ongoing that health disparities continue to persist for many in Oregon. Our dedication to doing this work was founded on the understanding that the earliest life experiences have lifelong impact on health and well-being. We know this from the research on adverse childhood events, as well as our own data, as we've described here throughout the webinar. We have been focused on prioritizing the needs of children and families throughout our health system and looking for new tools and ways to advance this work in our state. And this work that we are sharing with you today is a clear example of how we can move this work forward. Some of the most recent transformation efforts Oregon has undergone has been the development of coordinated care organizations in our state, which now cover the needs and health services for 85% of people on the Oregon Health Plan. Coordinated care organizations contract with a network of providers that provide physical, oral, and behavioral health care for members of the Oregon Health Plan, which includes over 1 million Oregonians. Nearly half of those are children. OHP includes primarily our Medicaid program in our state, as well as CHIP, but also additional covered services for members enrolled through Cover All Kids and our State Reproductive Health Equity Act, among others. Currently, Oregon is undergoing a new procurement for the next stage of our coordinated care organizations, or what we call a CCO 2.0. Currently, Oregon has a request for applications open for the next 5 years of our coordinated care organizations. We've spent the last 1.5 years plus developing the policy priorities for this next stage of coordinated care organizations that was led and directed by our governor, Kate Brown, as well as the Oregon Health Policy Board. Governor Brown identified 4 critical areas to direct the OHA and the Health Policy Board in developing those priorities for this next 5 years of CCOs, as listed here. First, one goal is to improve the behavioral health system and address barriers to the integration of care. In particular, behavioral health system for children and families were called out as a critical need. Second, our focus is on increasing value and pay for performance. Third, a focus on the social determinants of health and health equity, as well as maintaining sustainable cost growth and ensuring financial transparency. We see the work under Children's Health Complexity as touching every one of these 4 priorities for our next CCO efforts, and hope that you'll see that displayed throughout our presentation today.
So this is John Collins, and so the interest pretty much underlying all of those different focus areas that Dr. Harganani just went over is data, and we have tried to utilize data to a great extent in helping move forward with our health system transformation here in Oregon. One of the ways that we've done that is to basically attach performance metrics to each of our coordinated care organizations and track their performance, and based on their performance, we've actually set up a pay for performance system. And then we've also generated other reports that we share back out with the CCOs to help them better understand their data and their performance and some of the underlying constructs associated with this. A lot of that data and the metrics that we've generated has relied on a very robust system of encounter and claims data, but we've also started to delve into other data sources such as electronic health records and surveys. The information that we're going to be reviewing today around health complexity, social complexity, and medical complexity is another effort for us really to dive a lot deeper into the data and give our CCOs and the stakeholders associated with the healthcare system a deeper understanding of the needs of children who are enrolled in the Oregon Health Plan, and understand, one, at a very high level, how it's related to some of the metrics, but more importantly, so that we can direct resources towards those kids so that they can achieve better outcomes.
Thanks, John and Dana. So now a quick overview of the grant that supported the work we're presenting on today. OPIP, in collaboration with the Oregon Health Authority, received a grant from the Lucille Packard Foundation for Children's Health to focus on developing a system-level approach to identify children with health complexity, knowing that our ultimate goal was then to use that information to drive and inform better complex care management models for these children. The project supported us to work with OHA, the coordinated care organizations that OHA contracts with, and Kaiser Permanente Northwest. So we've been using a lot of terms like medical complexity, social complexity, health complexity. So I thought what I would do is kind of outline them for you in terms of the definitions we're using. So in terms of medical complexity, we built off the algorithm that was developed by folks in Seattle called the Pediatric Medical Complexity Algorithm. And this Pediatric Medical Complexity Algorithm takes into account utilization of services, diagnoses, and number of body systems impacted. And what it does is it then categorizes a child into three categories of a child's medical complexity. For social complexity, we anchored our work to the definition created by the Center of Excellence on Quality of Care Measures for Children with Complex Needs, or the COE. And they define social complexity as a set of co-occurring individual, family, or community characteristics that can have a direct impact on health outcomes, or an indirect impact by affecting a child's access to care and or a family's ability to engage in recommended medical and mental health treatment. And so health complexity is then the combination of those two. The combination of the blue plus the yellow makes the green, which is health complexity. So what we're going to do now is kind of walk through in a little bit more detail the methodologies that were used to operationalize medical, social, and health complexity, but then share along the way the findings for this over 390,000 publicly insured children in Oregon. So let's start first with that blue piece of the puzzle, medical complexity. So again, the tool we're using is the Pediatric Medical Complexity Algorithm, or the PMCA. It's a tool that is applicable and valid for children 0 to 18. It was originally developed to identify a population to stratify quality metrics and meant to address issues with the CDPS system. Again, it's based on claims and diagnosis information, and it yields 3 categories which are collinear with cost. In Oregon, we used the 3-year look-back period, so claims were examined for a 3-year time period. And the PMCA has a number of different versions that it offers in an ICD-9 and ICD-10 SAS code. And we use the most strict definition due to the high quality of data that John mentioned that Oregon has access to. So here are the findings for publicly insured children in Oregon, the 390,000 children that were used in the cohort analysis that we looked at. So what you can see is that nearly 25% of kids have special healthcare need according to this use of the PMCA model and the Pediatric Medical Complexity Algorithm. And of that 24%, 6.1% would be considered complex chronic, and 18.3% would be considered non-complex chronic, and 75.6% of kids were identified as healthy. We then analyzed the data across the counties in Oregon and across the coordinated care organizations in Oregon, and found statistically significant differences in the distribution of the PMCA categories. This is an example of that kind of statistically significant difference. This is a heat map that is showing you the proportion of children in that first category, the complex chronic condition. And what you can see is there are some counties where the rates are lower in that kind of range between 7.5% and 3.2%. And there are some counties that are quite high. So let's talk about the yellow piece of the puzzle, the social complexity. Again, we were really fortunate to be able to anchor our work to the Center of Excellence on Quality Care Measures for Children with Complex Needs. And the robust analysis that they did in terms of literature reviews, and then prospective analysis they did in looking at Washington and Minnesota Medicaid data. So what the COE found is that there were really 18 factors that meet that definition of social complexity, which I described in an earlier slide, and that have evidence and research behind them that show that those factors meet that definition and are associated with worse health outcomes and costs. So the 12 on the left were the original factors that the COE identified in doing a thorough lit review. And then the factors on the right were additional factors that their stakeholder consensus group of experts around the country identified and that they subsequently found were associated with higher healthcare costs in claims data in Minnesota or Washington. So in Oregon, what we decided to do is kind of look for these 18 social complexity factors and think about what do we have, one, system level indicators for, and two, could we identify those system level indicators at a child level for those over 390,000 publicly insured children. Again, because our goal was to come up with an indicator for each child that combined the information from medical complexity, social complexity, so that we could create a composite health complexity variable. And this is where significant collaboration and coordination across multiple agencies within Oregon was critical. John, you want to share a little bit more about that?
Yeah, so one of the tools, as I mentioned earlier, we've been looking for other tools to utilize from a data point of view to help understand our health system transformation. And one of those tools that we had available to us was something called the Integrated Client Data Warehouse. It's a shared service that we have within the Oregon Health Authority, and up until fairly recently, it had been used to collect and pool data from across a number of different services within the Oregon Health Authority and the Department of Human Services and some agencies outside for purposes of doing caseload forecasting. We saw it as a possibility to actually help us do the work that Colleen has just been describing, because what it had available to it was data for kids who had been participants in foster care services, SNAP services, mental health services, some of the various social complexity types of issues that Colleen just went over. So we worked with our Integrated Client Services Warehouse staff, developed the appropriate data sharing agreements, and had them link the information up. And after doing that, we worked with our public and private stakeholders to basically utilize that information to operationalize them into the various aspects of social complexity that Colleen went over earlier. Sorry. So, in looking at that information, basically we were able to leverage data from a number of different programs. Here within Oregon, the Oregon Health Authority itself represents information and services associated with Medicaid and behavioral health services. And our Department of Human Services includes services associated with people with disabilities, child welfare, developmental disabilities, self-sufficiency, vocational programs, and others. Basically, the ICS has set up in such a way that we're able to create a unique identifier across people who've utilized all of those different services, and in doing so, create units of both family units in terms of children and parents, as well as understanding what types of overlap there may be amongst those various services for both the children and the parents.
So this figure shows you the 12 indicators that are aligned with the 18 topics that were identified by the COE that we were able to identify at a child level in order to operationalize a flag about whether that child had experienced that social complexity. On the left, you'll see the indicators and the data source for the indicators. As you'll see, a number of the indicators are from the ICS data system that John mentioned, and some of them are from the Medicaid data system, either from Medicaid claims or from Medicaid eligibility information. What you'll see is there are certain factors that are associated with the child's use of services. There are 5 factors that are associated with the child's use of services. So whether the child accessed temporary assistance for needy families, or TANF, whether the child had ever been in foster care, whether the child received mental health services, whether the child received substance abuse services, and whether in claims data, Medicaid claims data, there had been a child abuse and neglect ICD-9 or ICD-10 diagnostic code. Then, as you probably saw in those 18 factors, a number of them had to do with the family's use of services or family indicators. So within the ICS data system, we were able to find 7 factors that related to the family social complexity. So whether the parent had ever accessed TANF, whether the parent died, whether the parent had been incarcerated in a state-level crime, whether the parent had used mental health services, whether the parent had used substance abuse services, whether the child at the time of enrollment in Medicaid, the parent indicated that they needed the information sent in a language other than English, and whether the child was eligible for Medicaid due to the parent's disability. So when we combined the 5 child-level factors that we were able to identify and the 7 family-level factors, that creates the total of 12 social complexity factors. As you'll see, we had to kind of make a decision about what was the look-back period that we would use. So for the medical complexity, we used a 3-year time period. For the social complexity, we chose to take adverse childhood events informed approach. And where it was possible and feasible in the integrated client data warehouse, we looked and saw whether any of those factors existed during the child's lifetime or the prenatal period. Then there are certain factors that you'll see in the table. So for example, parent disability or child abuse and neglect, that we had to use a different time period, either the most recent information provided at time of enrollment or a 3-year time period that mapped the claims data pool. An important note about the linkage for the family level factors. So for the child level indicators, those 5 indicators, all children were able to be matched within the ICS data system. For the family indicators, we were able to match for 80% of the children, but there were 20% of children that will have a 0 in the family indicators because we were unable to link to one or both parents. For a majority of the children, we were able to link with both parents, 67.94% of the parents. So on this slide is what you'll see the findings in terms of for that 390,000 publicly insured children, the prevalence of the social complexity factors. So as you can see, some of the higher rates relate to whether the child accessed TANF, whether the parent received mental health services. So about 158,000 children that were publicly insured had also accessed TANF. And 156,000 publicly insured children, their parent had received mental health services. It's also notable to look that 19.1% of publicly insured children, their parent, one or both parents had been incarcerated in a state-level crime. 29%, one or both parents had received substance abuse services. As we know, each individual social complexity factor was associated with higher healthcare costs. But there also is a gradient effect in that we know that the more social complexity that a child experiences, the higher risk that that child is in. So what this chart shows you is of those 12 factors, how many children had 0, 1, 2, 3, and so forth. So what you'll see is only 19.0% of children had no social complexity factors. 24.8% had 1, 17.3% had 2, and over a third of children, or 39%, had 3 or more. While that tail on the previous chart looked small in terms of the number of children that had 10 or 11 factors, thankfully there were no children that had all 12. That still represents a fairly large number of children. So for example, within Oregon, of the publicly insured population, there are 256 kids who had 10 or 11 social complexity factors. And when we think about that third of children who had 3 or more factors, that equates to 152,000 kids in the state of Oregon. Again, we examined for variations in the social complexity findings by region and by CCO. And again, we saw statistically significant differences in the rates of social complexity by region. So now let's talk about the green piece of the puzzle, which was meant to combine the information, again, from the blue, medical complexity and social complexity. And this is where we were kind of headed into new waters because nobody had created a health complexity categorical variable. So we kind of took from this thinking that we knew we wanted to create a variable that provided information about both because both impact the child's health and the ways we might build that child's resiliency. We also wanted to build off the learnings from the COE and from the adverse childhood events studies that show that one or more social complexity indicators are associated with higher healthcare costs or poor health outcomes. But again, there is this gradient effect. The more factors present, the higher the cost. We also wanted to create a manageable level of categories because we have created a number of population aggregate level reports. And so if we had a categorical variable that had 12 categories, for example, we worried that that would be a little bit too many categories. We also needed to make sure that because we were reporting the information at a county level, for example, that we needed to honor the data sharing agreements that were in place with the ICS data systems. And so we wanted to make sure that we created a health complexity categorical variable that ensured sufficient denominators that would allow us to be able to report the information at a state and county level. So this is where we landed in terms of a 9-part categorical variable displaying the health complexity of children. So on the left, you'll see is the 3 categories of medical complexity according to the pediatric medical complexity algorithm. So the first row is children that fall into that high medical complexity. The middle row is children that fall into the moderate medical complexity. And the bottom row is children with no medical complexity, again, according to claims data. The columns on the right then are the 3 categories we picked for the social complexity count variable. So the first column is children that had 3 or more indicators. The middle column is children who had 1 to 2 indicators. And the right column are children that had no indicators. So again, it's important to note that what we see here is there really are children that have very different levels of health complexity. And what we might do for children in these various 9-part buckets is really different. And the kinds of best match services we might provide for these children is very different. So for example, when we look at children with high medical complexity, what we know is a child that has high medical and high social complexity is going to need a very different level of support than a child with high medical complexity and low social complexity. So this data has been really helpful for us to kind of think about how might we think about the magnitude of children that fall in each one of these buckets, and then what might be some of the best matched sets of services for them. We've also just been really curious in looking at the data for the bottom row. These are children who currently don't have medical complexity, but if you look at that 26.5% of children, or 103,459 children who have already been exposed to 3 or more social complexity factors, some would say that they're likely in the future to have medical complexity, partially due to the social complexity they were exposed to as children. One of the important parts of this data was being able to disaggregate it for important groups that we might target important system and policy level activities. The data has been analyzed and reported by age of the child, by county, by race, and by ethnicity. This is an example of the data findings by age. So what you'll see is that as a child gets older, they're more likely to have a special healthcare needs or a medical complexity. So for example, adolescents that are 12 to 17, 7.9% of them had complex chronic condition, 23.5% of them had non-complex chronic conditions, and 68.6% were healthy. Conversely, though, a lot of people often think all young children are healthy. And so it's been really helpful to kind of show, well, actually, it's about 16% of young kids 0 to 5 already have a medical complexity that we might think about the kinds of needs that they would have in order to maintain their health and build their resiliency over their lifetime. This is an example of the social complexity findings by age of child. And again, this has been really helpful as we've been working with different stakeholders in the state around who are focused, for example, on children 0 to 5, to be able to show them the magnitude of experiences that publicly insured children have already in the first 5 years of life. So for example, you can see in this first column showing you the data for children 0 to 5, that already in the first 5 years of life of the publicly insured children, that there are 29% of them that their parent has, one or both parents has received substance abuse treatment services, and 44% of them, the parent has received mental health services. This is a really helpful way to kind of look at data and think about, well, what might be the kinds of best match supports for those children? Again, as we know, it's not only the individual factors that are important, but it's the gradient, the magnitude of the impact of those factors that is important. And so again, if we just look at those young kids, those 145,000 publicly insured children that are 0 to 5, we see that again, it still is a third of them, or 48,000, that have already experienced 3 or more social factors. And in terms of those young children, it's 12.4%, or 18,000 of them that have experienced 5 or more factors. One of the nice parts about linking the Medicaid claims data and the ICS data is that a number of those programs report race and report ethnicity. So we have been able to start to examine the findings by race and by ethnicity in order to consider kind of what do they mean in terms of best match supports, and what do they mean in terms of how we might engage community level partners that represent those organizations, those populations well. So this is an example of the pediatric medical complexity algorithm findings shown by race. And what you'll see is there is statistically significant differences by race in the pediatric medical complexity findings. This is an example of the pediatric medical complexity findings by ethnicity. And again, here we don't see necessarily statistically significant differences. And this is the social complexity findings by race. So one thing to just pull out, for example, is when we looked at the publicly insured children who were identified as Black, 51.4% of them had 3 or more social complexity factors. And so as we're thinking about important community partners to engage, this has been really helpful to kind of think about the kinds of experiences that different populations of children are having. Again, the richness of the data is in the combined story. So as we're thinking about complex care management models and recognizing the impact that medical complexity has in terms of what might be best matched complex care models, but also social complexity and what it has in terms of complex care models, it's been really helpful to be able to kind of look at, relative to that 9-part categorical variable that I showed you earlier, the variations in the findings and the recognition that for certain race groups, what we see is that if they have medical complexity, the likelihood that they also have social complexity is quite high. We also can look at the children that currently don't have medical complexity, but have high social complexity, so that first yellow row that you see in this chart, and think about what might we do to kind of build health and resilience in those children to try to prevent the development of health complexity. So that's a lot about the detail of the data, but the importance of the data is its use and its ability to inform and guide efforts statewide. So do you guys want to share a little bit about how this data is being shared at a population and system level in order to guide and inform efforts?
Yeah, so this is very much not an academic exercise for us. We really did all this work so that we can put the data out there on the ground, at the ground level, and have it be used for a multitude of purposes. At this point, we've generated 3 different sets of reports. One set is based more on population level, so that people can look at this information either from a statewide point of view or from a county level point of view, and utilize the information, a lot of which Colleen just went over, but then there are several other views of the information, and they can utilize that information to better understand their population and plan for services, with public health as one example, or county programs as another. Another effort associated with this was to share the information back with our coordinated care organizations, the CCOs. The CCOs were very involved with us in operationalizing a lot of the different aspects of the health complexity and social complexity and medical complexity pieces. So we wanted to make sure that the information got back to them at a level that was usable for them. So we put together aggregate information for the CCOs as well. And finally, for the CCOs, we also put together person-level information that we were able to send back out to the CCOs for children that were enrolled within their population. when we got down to that level of detail, we obviously were not able to give all the details in terms of what kinds of social complexity the child may have associated with them, but we were able to group the information and provide them basically categories of data so that they can go back and analyze that. And in doing so, they were able to attribute kids to, for example, some of the various pediatricians that they might have been involved with or other types of services, and also link them to some of the performance metrics that we also track for the CCOs. So, I mean, that was our really first push in terms of getting the information out and in a way that was usable for both the CCOs and the general population within Oregon. And in the future, we're actually hoping to ramp up our reporting piece, so that whoever is wanting to access the information might have some flexibility to generate some of their own reports at an aggregate level. Because one of the things that we've definitely seen, and Colleen mentioned way back towards the beginning of this presentation, is that we have to share the data for people to use it, and it has to be meaningful for them to use it. So we've always made a strong effort with the various performance measures that we have for the CCOs to be transparent and talk about the data as much as possible, and that's certainly our goal with this information as well.
So in addition to what Colleen and John have shared in terms of our interest here, we are really focused on how to take this data and build it into an action-oriented approach to improve the health for children and families. Certainly one of those at the forefront for us today are with our focus on our next 5 years of our coordinated care model. And I've already articulated the 4 key goals that have been the foundation for developing our policies and requests for applications for our next stage of CCOs. We are explicitly working to look at how we can consider this health complexity data to think about how we build out our pay-for-performance systems within the state. For example, as John has mentioned, how do we look at this data across our performance measures? And how can our CCOs and other partners utilize health complexity data, for example, through risk stratification around their value-based payment models? We are certainly looking at this data to help us understand the breadth of behavioral health needs for families, both the children and the family, the parents in the family, and to better target our approaches to improving access to services and integration of care that they need. We are also using this data as a clear opportunity to move from kind of an understanding of the research on the social determinants of health and equity to really operationalize these tools to directly drive our thinking and resources to address those social determinants. And finally, this data, as we've already noted, its connection to cost in the health system, we can really show in terms of number and data within our state and our regions what the impacts of health complexity are having on the overall cost growth in our state and how we might start to tackle those differently. At a statewide level, we are also clearly looking to think about how this data will help us understand how to better improve the care coordination for children with complex healthcare needs, how we might better deliver on culturally responsive approaches to families, particularly to address the health disparities that we've identified. And in addition, help us to better understand how we can build on our current ICS database and our data agreements to maximize this data to understand how we can address the needs of children and families. One of the first steps we have taken in order to move into this action stage is to bring the Oregon Pediatric Improvement Partnership on board as a contracted partner to help provide technical assistance to our coordinated care organizations and other community partners. We've organized this technical assistance into 3 main buckets. So first, giving our partners the opportunity to utilize the population level findings in this health complexity work to engage community partners. This will help communities to better understand the needs of children and the families in their region, identify what the community level assets are, and address the capacity of services that are needed to serve the unique needs of children with health complexity. Secondly, we're working on our TA focused on using the population and child level findings to identify opportunities for enhanced care coordination and care management, and to ensure we have the right centralized supports to address the needs of these families. And then finally, we're looking to leverage this data through technical assistance to help inform frontline healthcare providers, how to use this data to think about trauma-informed and culturally responsive approaches to care, and again, thinking about how this data could be used through the development of value-based payment models moving forward in our state.
Great. Okay, so we hope that that provided you with a good overview of the data that we were able to operationalize, the methodologies and potential uses. But we want to move now to different questions that the audience has for you guys. So I'm going to start first with a question that we often get asked about kind of how do you deal with some of the legal issues and just kind of stigma issues around kind of identifying these factors and sharing them. So the specific question was, how did you go about overcoming some of the ethical legal issues with linking parent and child health information?
Well, this is John. So as we discussed during the presentation, all the information that we utilized to combine and come up with these different indicators was available through the various agencies that contributed to them. And we worked with those agencies in terms of what the project was about and what our intent was with the data to develop data sharing agreements. All the information that's been shared out has been basically, its level of protection was based on those agreements. For the most part, the county level data or the statewide data or even the CCO aggregate information is set up in such a way so that you can't trace any of the data down to any particular individual. Where we have shared information at an individual level back with the CCOs, we blinded the details and basically replaced them with some of the categories that we use to represent the aggregate data so that the CCO could potentially look at an individual and see that this person has high complexity and a certain number of the social complexity factors, and based on that information, they fit into this place on that 9 categories of health complexity. But again, we did that in such a way so that they could not trace the information back down to understand that, oh, this individual's parent was involved in substance abuse services and so on. So it was a little bit of creativity, but and a lot of aggregation to basically make sure that we were hiding some of those details. And then to go beyond that, though, because we wanted them to be able to use it, some of the training that Colleen and her group are doing is basically in terms of how they can utilize that aggregate information, even if it's for the individual, and approach them in a trauma-informed way to get some of the details that might help in terms of coordinating the services or deciding what services are needed.
Anna, do you want to add anything?
No, I guess I would just say, in addition to what John already articulated, this, while we see this aggregate level data in particular being particularly useful for coordinating community systems and best matched resources, it certainly goes truly alongside efforts that might be happening at a frontline provider effort. For example, screening activities across a patient population that can help identify specific needs of a particular child or family. So these two really we see as going in combination together as best supports for children and family, but neither, neither alone will meet the needs, I think, of children and families, and together we can really leverage this focus alongside protecting the information that John has already identified.
So there were a couple questions to kind of around that 20% that we were not able to link. And so I want to kind of clarify kind of where they fall in the data. So again, the goal of the health complexity variable was to be able to identify children for which we already had system level flags and indicators. One of the really important parts that we share consistently is that, in a sense, this is the best worst case scenario, because these are only the things that we see at a system level. So for example, we don't see children who need substance abuse services. We only see children who access substance abuse services. So in terms of the medical complexity, all children, we were able to analyze their medical complexity. So for all children, we have data in that blue bucket. And for all children, we have some data in the yellow bucket. So all children are in the pool in terms of being able to give information, or we were able to look and see whether they had one of the 5 factors. Where the 20% comes into play in terms of where for a population we're missing information is on those 7 family level factors. We still decided to include in the total count the children who aren't matched because we still have information about their social complexity and we have information about their medical complexity. Again, we're missing for those 20% part of their social complexity information, but we didn't want to remove them because we had information in that yellow bucket and we had information in the blue bucket. There was somebody who asked a question that I think might be from a coordinated care organization in Oregon about could we at a CCO level be able to distinguish children who had weren't able to be linked for the family level factors. And as John mentioned, you guys got the child level variables that were blinded. And in those child level variables, you got 3 of those social complexity count variables. So you wouldn't be able to tell whether they hadn't been able to be matched because, again, we had to honor a lot of the data sharing agreements that exist within ICS. But what you could look at is you can look at children that have 0 to 5, and you can look at children that have 0 to 7. And a group of those children that have 0, it's because they weren't able to be linked. So that's a way, and again, a reason why we wanted to be able to give CCOs the blinded count variables, because as I'm working now with a number of CCOs, the 9-part variable is a really helpful variable to use for population reporting. But in some of this drilling down or understanding who might be better to do secondary follow-ups or additional care coordination and case management, a number of CCOs are having to come up with kind of a different configuration of the variables, frankly, because the 9-part is so big, it's too many children for them to be kind of able to hone in on. If you have additional methodological questions, put them into the chat function or the question function, and then I can make sure to follow up with you after the call in order to answer a lot of the detail. So one of the questions that we got was, how did you get your state to pay attention to children with complex needs? We are struggling because almost all state efforts here are focused on adults with chronic conditions. Do you guys want to, you're the state, and then
well,
how do you want to go about
as the data guy, I'll answer first, but then Colleen and Dana can add quite a bit more detail. I think the first thing, and this is true for a lot of information that we have access to through at different states through our various administrative data sets, it's coming up with a good way to consolidate the information that comes across, is fairly easy to understand, and is meaningful to the audience that it's being presented to. Some of the detail that we did not go over in terms of this particular project was all the public engagement that we went through. There were several, 4 or 5 different public meetings that we had where we engaged a broad swath of stakeholders associated with children and talked about this, and then worked with them to operationalize it so that the participants in those various meetings were actually participants in this study, and that they helped us actually define a lot of the elements that we worked together. But I think it really all came down to presenting the information back to them in a way, as I said earlier, that was meaningful and could be utilized in a number of different ways. And that really engages the folks as an audience. And but I'll let Colleen and Dana kind of go on from there, because children is a very large focus here within Oregon.
This is Dana. I'd be glad to just add my perspective on this. I do believe in Oregon that we've been really lucky to have significant leadership in our state over many years, understanding the importance of focusing on children. I think that's been driven through pretty clear, the clear research now that lifelong health and well-being really starts in the earliest phases of childhood and through the prenatal periods. We've really, clearly understood and paid attention to the research focused on the social factors and how they impact health, such as through the adverse childhood experiences, and really understanding that if we want to move our overall health system and, frankly, education and other system goals, that we really need to start with the youngest kids and families to really make that difference over time. The leadership that has helped to drive this agenda focused on children, and in particular children with special health needs, includes our current and past governors, agency leadership, partners such as the Oregon Center for Children and Youth with Special Health Needs and the Oregon Pediatric Improvement Partnership, and many providers across the state. So this has been really a focus for many years, and I think this really opportunity in front of us today really lends itself to the work we've done within the coordinated care model and leveraging our data to really keep moving our transformational efforts forward.
I will just share, I do think we're in a great state that's kind of thinking about value-based models, thinking about quality, measuring quality. As an organization that tries to put children first and focus on children being healthy, part of the reason we wanted to kind of complement and support the frontline work that we've been doing focused on children with health complexity is that even in a state that has devoted a lot of energy around patient-centered medical home, and even in a state that has thought about a coordinated care model, we still, similar to what you have noted, have seen that sometimes, particularly in a global budget environment, you might want to focus on those people that cost you the most money. And so part of the reason why we wanted to go upstream in terms of thinking about system-level data is what I noted at the beginning, is what you measure is what you focus on. What you can track is what you focus on. A population you can identify, you can think about value-based payments. And so I think one of the gaps that we as a field hadn't given to our policymakers was how do you identify this population that we're telling you is so important to target investments and resources? And how do we share with state policymakers the gaps and the needs of children? And so having this system level data I've observed has really been kind of a galvanizing force to say, this is the magnitude of issues that we're talking about in terms of children. This is why this population is important. And it's kind of helping create some of the cross-sector conversations that are needed once you have kind of quantifiable numbers, not only at a state level, but within your specific regions. One of the questions was around kind of, have there been discussions with CCOs and policymakers regarding reallocation of funds to higher needs or underfunded areas in the state? They're specifically interested in incentivizing medical providers in rural areas, which typically have recruitment challenges. Curious about your guys' thoughts around that.
Well, this is John. I'll just say that at this point, any discussion around how the money's allocated back out to the CCOs has been very general in terms of this data. I think it would demand a lot more exploration. However, I do understand, though, that that would be entirely possible for the CCOs as they're looking across their population. And our CCOs range in geographic size from many different counties that are quite large but not very populous to some smaller counties that are very populous. So how they utilize the information and decide to use it to perhaps distribute funding and resources to meet the needs of their population. And that is one of the basic reasons why we generated the information in the first place. But they have a lot of flexibility in making those decisions themselves.
So one of the questions was about kind of what we're starting to see. This data was just released to the coordinated care organizations in December. What kinds of ways are we seeing the coordinated care organizations using the information? So as Dana mentioned, part of the reason that OPIP thought of these kind of tracks of technical support is that we really thought each one of these was really important. That you first need to kind of understand what the data says and doesn't say, and you need to kind of understand what kinds of assets and resources exist in the community and which ones don't. So OPIP is working with a number of CCOs right now on actually how do they share their population level data reports with their community level partners so that they can identify what priority areas do they want to focus on, what assets do they want to leverage, and what investments and resources might they want to make in order to serve the population. The second track of efforts is really around how you might think about the data to inform population and child level findings in terms of the complex care management. So for example, we're working with a coordinated care organization right now who's thinking about developing a pediatric complex care management position. And so we've been talking to them about kind of like, well, what would be the training and the role and the outreach methods that that person would be able to do? And then how do you think about what kinds of children might be a best match for that type of support and services? And then how might you leverage community-based resources that also provide complex care management in that community? And then the third track of work that started with CCOs is around how they might use a health complexity data-informed approach in terms of the frontline pediatric providers that they contract with. So for example, some of the CCOs have analyzed their child-level data by the primary care practice or the medical home that the child is attributed to. And they're looking at kind of the variations in the rates. It was very clear that there are some practices that serve populations with very high health complexity. And so how might they think about building in some of the population level findings into some of their outreach and training efforts around how could that practice be trauma informed? What kinds of infrastructure or value-based payment models might be valuable for some of those practices that see higher groups of patients. They've also started to look at the findings by zip code in order to kind of understand, are there specific regions or communities that they might invest in community health worker or patient navigators that might also be a support to families in those regions. Okay. Another question that we received, and this might be, we'll see how long this takes, is there a future plan to weight various social factors based on evidence linking them to health outcomes, potentially using published odds ratio or risk ratios? For example, reports of abuse versus TANF being weighted differently. This is an area that we struggled with a lot and got a lot of public feedback on. So again, as you see, we have these 12 factors. And what we decided to do for this first wave of data sharing and for this first wave of data analysis is to count each of these factors as equal. In some of the COE data, for example, the TANF indicator was actually the highest predictor of emergency room use. But that would be then deciding to say that emergency room was our most ultimate outcome. So in talking to various stakeholders about, one, whether we should weight these factors or not, we ultimately landed on not weighting the factors. I do think as we continue to use this data, that we might think about whether there are certain factors, particularly when clustered together, that would indicate a higher level of risk. So we've looked at correlation or clusters of factors, and you see ones that kind of clump together. So for example, there is high correlation between substance abuse of the parent, mental health of the parent, and parental incarceration. And so we might think about creating some new variables or categories that would help indicate kind of a composite level of risk there. You will see that by virtue of mental health being included in the pediatric medical complexity algorithm and being included in the social complexity algorithm, that somewhat by virtue of just the sheer number of counts then does weight mental health to some degree. And then poverty is obviously weighted twice because we look at whether the child accessed TANF and whether the one or both parents accessed TANF. And that was a weight, again, that we were comfortable with because of the higher odds ratio that the COE saw for TANF. But again, I think this is going to be one of the areas that as we have the next 2 years to kind of think about the data and how it's actually used on the front line and at a community level, we're really interested in learning about how to make it better and what opportunities there may be. Is there anything you guys want to add to that question?
No, then that was a great question. It's definitely something we're wanting to explore.
All right, so since we only have 2 minutes, I think what I'm going to do is, what Lucille Packard will do is they'll send us all the questions that were submitted, and then what we can do is we'll make sure to provide a response to all the questions at the end so that each person gets their questions answered, but they'll be publicly shared in case you are interested in the answer to the question as well. So with that, that's the end of our webinar. We really appreciate you participating. Again, you can access the summary brief in the link in the chat section that's on the Lucille Packard website. Additionally, on the Oregon Pediatric Improvement Partnership's website, you can access a lot of information about the full project that we did, learning sessions that we did with the coordinated care organizations. We have compendiums around best match complex care management that are provided there. And then if you're interested in seeing additional information about the data that was released by the Oregon Health Authority, the state level report, the county level reports, or other information, you can find that on the Health Analytics website, which is linked here. Thanks again for your participation. We really appreciate it.